Hello and welcome to another insightful episode of MedSynapse podcast series, where we connect you with leading minds to advance your clinical practice. I'm your host, Ketvi Shah, and today we're discussing decoding head trauma, the latest insights for clinicians. And joining me is Dr. Anuvrat Sinha, an experienced neurosurgeon at Artemis Hospital, who has worked with prestigious centers like MGM Healthcare Chennai and Narayana Health in Gurugram. He specializes in complex brain tumor surgeries, spinal procedures, and advanced minimally invasive neurosurgery, integrating technology with neurosurgical principles to deliver transformative patient outcomes. So, welcome, Dr. Sinha. It is such a pleasure to have you with me for this conversation.
My pleasure too.
Thank you, Doctor, for joining. So, let's just dive right into the topic, Doctor. So, from your experience, what are the most common causes of head trauma presenting to the emergency department today? And have you noticed any changing trends in the recent years?
Yeah, traditionally speaking, the head injury cases, most of them are RTA, the road traffic accidents like two-wheeler accidents, car to two-wheeler collisions, pedestrian accidents. Apart from that, in the recently changing landscape, we have seen with the more evolution, better industrialization, the new buildings are coming up. So more, we have recently started getting more of fall cases, fall from height. Then assault cases have come. So these like, and for in case of children, fall from cot, fall from the baby chair, all these cases are also coming up. So obviously, with more industrialization and more advancements in the technology, the modes of injury have also started changing.
So, Doctor, thank you for sharing that insightful answer with me today, Doctor. So, now when assessing a patient with head injury, what are the key red flag signs clinicians should never miss during the initial evaluation?
Yeah. So the key signs which I would like to say apart these include like mainly what the patient is complaining in case the patient is having very severe headache or we feel the patient is a bit drowsy, not very much responsive, not responding to commands, or if the patient is having recurrent vomitings, blurring of vision, weakness on any one side of the body. These are the symptoms which we should look for. Then clinical signs, I would say these include the GCS score, that's the Glasgow Coma Scale. That's like the status to, that's a scoring system to assess the consciousness level. Apart from that, the size of the pupils, we have to look for any anisocoria. Then the power, if there's hemiparesis, hemiplegia on one side of the body. These are like some of the major signs. Apart from that, we have clinical this parameters like blood pressure and pulse rate. If there is bradycardia, the pulse rate is going down, or if there is a too much of high BP, these can also be related to intracranial injuries.
Now, Doctor, could you elaborate on current surgical interventions for traumatic brain surgeries? When is surgery indicated, and what are the factors determining the choice of the procedure?
Yeah, so the current scenarios in which we are operating usually these include presence of an extradural hemorrhage or a subdural hemorrhage, or we would say depressed fractures, skull base fractures. All these are the indications. Contusions, traumatic brain contusions. These are also some of the indications. Radiologically speaking, if there is a collection more than 30 ml in case of an extradural, or if there is a midline shift of more than 5 on the CT scan, apart from the clinical features, these are some of the indications. If the patient is having CSF rhinorrhea, leak from the nose, or skull base fractures, pneumocephalus is there, and GCS score of less than 9, less than 8, I would say. In such cases, these are clear-cut indications for surgery. In surgeries, what we do usually in case of a collection, we do evacuate that collection. We do a craniotomy, evacuate it. If there is a pressure effect on that, then we remove a part of the bone, what we call a decompressive craniectomy, and store it in the abdominal wall. And then it stays there for around 1.5 to 2 months. Later on, we replace it with a cranioplasty, which is an elective procedure. So as a life-saving, mostly what we are offering is decompressive craniectomy.
So, like, these are like tailored factors, and I think various factors coming to picture. Obviously, it is tailored to each patient's conditions. So now, doctor, how do you approach the management of patients with severe traumatic brain injuries, particularly in terms of neuroprotection and preventing secondary insults?
Yeah. So first of all, we need a dedicated neuro ICU, which are trained neurocritical care staff, neuroanesthetists, and the nursing staff. Then during that stay in the ICU, for especially for severe head injury cases, we have a number of measures to keep a check on the intracranial pressure. We have to see whether the ICP is rising. Then we have to maintain an adequate cerebral perfusion, the CPP of the brain, so that the brain gets adequate amount of blood to function. So in post-traumatic cases, what we do, we generally keep the head end elevated, and we give anti-edema measures like mannitol, hypertonic saline to keep the rising ICP in check. Then we have this method called a hyperventilation to reduce the ICP. Then there is a way, less invasive way, what we call a ICP monitoring. It's like an ICP monitor which is inserted into the brain through a burr hole in the scalp that gives a real-time measurement of the ongoing intracranial pressure. So these are the measures. Then apart from that, we have to maintain the multiple organ dysfunction has to be prevented. So other factors like kidney function, liver function, all these things, lung status, elective ventilation, all these things have to be taken care of so that secondary insults are prevented.
That was quite insightful, doctor. Thank you for sharing that. So now, doctor, finally, what is your key message to emergency physicians, general practitioners, and young neurosurgeons regarding the optimal management of head trauma cases?
Ideally, I would say if any such case comes in the ER for an emergency physician, they should have the basic know-hows of how to evaluate a case, what all clinical signs and symptoms need to be taken care of. They should have the basic knowledge of how to read a CT scan and when to call the concerned neurosurgical team. For young neurosurgeons, I would say that we should keep our margin of this threshold of intervention should be kept very low. Like whenever, as and when we feel that there is a need of intervening, either surgically or medically, we should be very much proactive. We should not let these cases slip away just like that, because they have a very high chance, a very high likelihood of deterioration in the cases where they don't get optimum care at the right time. So what we say usually, the door to OT time should be within ideal best is within the first hour of accident, but still within 4 to 6 hours also does help the patient a lot.
Yes, doctor, that was quite an insightful answer, and thank you for sharing that valuable piece of advice with all the clinicians hearing this today.
Thank you so much. My pleasure. Thank you.
Thank you. And to our listeners, remember, if you're a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, stay updated and work collaboratively to ensure every patient receives the best possible outcome.